My report tonight consists of one item, and that item is to receive a report on the elimination of health disparities in Mecklenburg County and to hear recommendations regarding a call to action. As you might recall, last year in October, you approved, as a part of my management plan, one of the items upon which you judged my performance, me including an item that that proposed making the elimination of health disparities a priority, and to coming back to you with recommended strategies that we might pursue. I first want to thank all of those who have been a part of this effort up front for their work, notably our Public Health Department, Ms. Janice Jackson of my staff, and the many partners that we have in the community. Before I call Janice Jackson to come forward, I would like to read just briefly from your 2015 vision plan. It reads in part, in 2015, Mecklenburg County will be a community of pride and choice for people to live, work, and recreate. It goes on to say that we will have eliminated preventable child deaths and injuries and have no disparities in resident health based on ethnic background. We will have the lowest per capita incidence of substance abuse in the nation and have lower than the national average per capita cases of cancer, HIV, AIDS, and other sexually transmitted diseases, heart disease, teenage pregnancy, and infant mortality, among many health indicators. I think it's very fitting that we come here tonight to look at or to hear this recommendation as you also consider your vision for 2015. It's also notable that tonight you considered two other items related to public health, as you declared in the resolutions that you read tonight, National Alcohol and Drug Addiction Recovery Month, as well as Fetal Alcohol Spectrum Disorders Awareness Day. And on a personal note, Mr. Chairman and members of the board, as an African-American male, today I will share a personal story with you. I had my annual physical. My blood pressure today, even though I come from a family with maladies related to hypertension, my blood pressure read today 110/70. Oh, no. My sitting pulse count today was 60 versus 61 yesterday. And I offer that only to you because I take seriously my own personal health in light of what we struggle with, and know that I, as an individual, have to have some personal accountability if I'm going to be helping you lead the charge about the elimination of health disparities in this community and helping you fulfill your vision for this community.
I think there have been positive changes based on this strategic plan. We look at changes in two different areas. The first is, are we doing some things to strengthen our prevention programs so that our citizens remain healthy? The other is more on the intervention side. If we are finding citizens with various health problems, what are we doing to stabilize them or improve them so they don't have this disparity in the outcomes of morbidity and mortality? I think on the prevention side, I think what the county has done, along with partnering with the Charlotte-Mecklenburg schools, is to strengthen the school health program, which really is reaching out to our children, the younger generation of this community, hopefully to put them on a pathway to maintain good health. This gets into all sorts of important programs, teaching good nutrition, teaching the value of exercise, teaching the value of avoiding high-risk behaviors. If we can have a strong and continuing influence on the younger generation, that's going to ultimately help us turn the corner on health disparities by having uniformly a community that's healthier, more active, more productive. On the intervention side, I think one of the most important things we've done in terms of health disparity problems is focusing on the HIV situation in this community, where there's a predominant number of African Americans with HIV, particularly African American males. and looking at ways to identify these individuals with HIV, living with HIV, get them into care through our new Ryan White program, which is a federal grant that allows us to have $4 to $5 million each year to put those in the greatest need into care, into support. And by keeping our individuals who are living with HIV in a healthier condition on medications, in care, they're not only healthier, but they don't have the risk of basically giving the disease to others in the community. So it's basically a win-win situation. Those are the two areas that have, I think, the earliest and highest impact of what we're trying to do in this very difficult and complex health disparities situation. Well, I think this is where we get into, again, making sure that we keep monitoring the situation, that we help both the citizens and our political leadership at the local, state, and national area aware of what our problem is, because some of the real important solutions are going to take a very coordinated approach. And probably one of the most important things in terms of improving the overall situation is trying to find the improvement in a healthcare system where every citizen in our community has an opportunity to get affordable health care. And we're not anywhere near that. And the problem now is with the difficulty in the economic situation, we have actually more and more of our citizens who are not under any sort of insurance plan. They don't have a medical home. And if they do have diseases, they usually have to use the emergency rooms for care, which is not a good primary care source. And if they have chronic diseases, their conditions may worsen because they can't afford to maintain either continuity of care or their medications. So we have some real challenges as a healthcare system, and I'm hoping national healthcare reform will allow, our citizens to have equal access and affordable care in the future.
I'd like to introduce a phrase that I learned some years ago. It's called cultural discontinuity. And that phrase comes to me by Dr. Agbu, who was a Nigerian anthropologist, taught at Berkeley University. And it simply means that when you bring individuals from their native environment into an environment that is not their own, what does the receiving entity, be it the school systems, the hospitals, churches, what do they do to become more receptive, to become more culturally sensitive, linguistically competent in those areas? What I've noticed is that in the growth of the Charlotte-Mecklenburg area and the numbers of refugees that are coming in from overseas, the receiving institutions don't have adequate amount of time to prepare themselves to be culturally competent or to create the continuity for these populations that come here. And just to give you an example, there are two major resettlement organizations here in the city. One is Catholic Social Services and the other is HIAS. And both of them will tell you that they will get a moment's notice. So right now they will get a notice from Office of Refugee Resettlement in D.C. or elsewhere and say, we've got a family at the airport, can you go receive them? And they will then have to move. So with the number of people that are coming in, and I'll just give you an example in terms of CMS. For now, there's well over 140, I believe, languages that are spoken in our school systems. We have Somali Bantu population that are here. They speak two distinct languages, Mai and Kisegua. The Burmese, the same situation where you have two distinct languages. So even within one ethnic community, you have differences in languages. The Montagnard community, the same situation. So for our school systems or health centers, DSS to prepare themselves adequately to meet these changing needs is quite a monumental task to ask of them. But I think the key element across all of our services that we provide in the county would be communication. And I think that's the one thing that I see that is lacking, that we don't have enough communication within the agencies themselves and across the agencies. One of the things, to Mary Wilson's credit and what's happening at DSS, is that they've actually created a division for immigrants and refugees. And now they're making those contacts across community organizations and across the consumers themselves to better understand and therefore deliver services as needed.
First of all, I think that the overall response to that would be that they need to work together. I think that the rate of change with issues and circumstances in any of the communities is going to cause us to be able to have to work together. We can no longer be effective in operating in just silos and turn around and being geographically territorial. The rate of change and the rate of issues that any culture or community could have at one time causes us to have to turn around and start working together. We have to build a model that encompasses faith, public, private sectors coming together and working as one and working in unity to solve the problems that we face in our communities. Looking at the faith-based community, one of the things that we're involved in now is an initiative working with Cheryl Emanuel from the Mecklenburg County Health Department, and it is an initiative that she has worked with us being the Western North Carolina Empowerment Collaborative, which is an organization that has come together to look at health disparities, period, but specifically this initiative deals with African American men's health. We find that there are many complexities as it relates to the African American male, and there are a tremendous amount of health disparities. And what we've found out is that a lot of males are not involved at the decision-making level around the table when it comes to looking at men's issues, whether it's health, whether it's mental, whether it's physical, or whether it's financial. A lot of the males are left out of the decision-making power when it comes to issues that concern them. And so one of the things that we're doing is raising the awareness and also promoting educational awareness to African American males and also trying to be involved at the table of decision making as it relates to African American males.
Well, I think that there are many things that we have to do. One is access. People have to be able to get into a doctor's office to really be able to receive the kind of care that they need. And so access has to be better. And access has to be better on multiple levels. We often think of just the doctor's office in terms of the primary care, the fee-for-service type of office, and that's important. The medical home there is important. But we're going to have to think about medical homes in regards to the safety net community and free clinics and access there as well. But I think patient access is one of the biggest things that we have to do. And then once a person gets into the doctor's office, whether it's routine care or chronic care, then we have to make sure they're getting quality care because there are unfortunately situations where people they see a doctor but they're not getting equal care. And so we've got to make sure that we're providing for everybody the same level of care. And so quality care has to be there as well. We have to also make sure that the care that people receive is culturally and linguistically appropriate. And what I mean by that is if I have a Hispanic couple or person that I'm caring for, and I really don't understand some of the cultural nuances with that person, then it's going to be difficult for me to give them the right care. I may give them the care that I think is appropriate, but if I don't know some of the nuances, I may not be able to do that. And one of the things that when I think of cultural competency that really comes to mind with me is language barriers. When we look at the Hispanic population and we look at a simple word, O-N-C-E, it's once, it's 11, but for us it's once. So if I'm a doctor who is really very thoughtful and trying to do the right thing, and I say very loud to my Hispanic patient, take this medicine once a day, ONCE. Well, what have I told that patient? I've said to them, take this medicine 11 times a day. Did I know that I was doing wrong? No, that I did not. But I have potentially just caused a fatal error to occur. And so cultural competency has to be part of what we do and do better than we've done in our past. So I think that those are the major things. If we could get those right, I think we'd be further down the road to being able to closing the gap.
I think that when we talk about healthcare disparities, in general, we have to first of all determine which stakeholders are involved in the solution. Before we talk about solutions, we have to make sure that the potential stakeholders that can effect solution come together and acknowledge there to be a problem. So I will submit to you, first of all, that the stakeholders are many, and they include consumers of healthcare as patients, and indeed all of us, irrespective of our socioeconomic background or our works of life, will at some point in time become patients. So we will all become consumers of healthcare. And therefore, in certain populations, we will also become exposed to potential disparities in healthcare. The next segment of a stakeholder entity I'd like to refer to is people that provide healthcare, such as physicians and nurses. Those also have to acknowledge there to be a problem. I also submit to you that the third category in this equation is healthcare systems, such as hospitals and clinics. So when you put those three categories of stakeholders together, we have to unite around the fact that there's a problem of disparities. And once we do that, we need to understand that the people that are affected with this issue of healthcare disparities are community people, and the community is an asset. So we have to now rally around a corrective action to preserve our asset as a community. And by so doing, we're able to then divorce the competitive issues that come to the table that involve healthcare providers and healthcare systems if we unite around the rallying call that we're trying to enhance the asset in our community. And by so doing, we can then begin an unbiased dialogue together, all stakeholders trying to solve the problems of access, quality, disparities, and inequity together. Healthcare disparities is a buzzword that's gotten a lot of traction over the past 5 to 10 years, and it has been applied more so to disparities that impact minority populations. The truth be told, however, that healthcare disparities do not just impact minority populations by way of racial minorities. There is an opportunity to equalize health across all populations, whether they are minorities or otherwise, because disparities actually exist, not just in minority populations.